Good morning, everyone. My name's Aoife. I'm coming from Ireland, and my title kind of gives it all away, but I suppose I'll talk a little bit more about cerebral amyloid angiopathy and recurrent venous thromboembolism. So CAA, it's an increasingly commonly diagnosed condition in the aging population, and there's no current treatment. The mainstay of treatment is really avoiding anticoagulation if possible. And with the increasingly widespread availability of MRI, we're now able to visualize asymptomatic hemorrhagic events, and trying to manage these has become a bit of a difficulty. Recurrent venous thromboembolism, they have the ability to be a life-threatening condition, and this is treated with lifelong anticoagulation unless a provoking factor can be identified and treated. And so our case, involves a case in which these two conditions, they coincide in the acute setting. So a 59-year-old lady presented with a one-day history of expressive dysphasia. She had a background of recurrent VTE, for which she was on anticoagulation on apixaban. She also had a background of obesity with a BMI of approximately 40. On examination, when she presented, she was called in as a fast call, and her NIH stroke scale was 3. That was for her expressive and receptive dysphasia. She was vitally stable with a GCS of 15. She also had some subjective reduced sensation in her right hand, but the rest of her examination was normal, and she was a lady who was right-hand dominant. She had a CT brain immediately as part of a fast call, and they showed acute bilateral temporal hemorrhages with no mass effect. Her bloods were grossly normal. Her ECG showed sinus rhythm. She was discussed with hematology, her anticoagulation was held, and she was given andexanet alpha for reversal of her apixaban. Her case was discussed with neurosurgery, and she wasn't for any intervention. These are just images of her scans, but unfortunately she had further neurological deterioration with bilateral hearing loss, and her GCS dropped then to 11 out of 15. Over the next 48 hours, she had frequent imaging showing further areas of bleeding and areas of expansion of her prior hemorrhage. And on the left, you can just see these areas of bleeding highlighted on a non-con CT. And on the right, there's an MRI image showing the areas of bleeding, but also areas of secondary infarction. She was managed in the ICU, mainly conservatively, just for monitoring. She didn't require any intubation, and her GCS did gradually improve over several days, and then she was transferred to the ward, had an improvement in her communication symptoms and her mobility, and eventually was moved to the rehab. We then had to discuss what to do about her anticoagulation in this acute phase. Obviously it was held given the bleeding, but she had VTE prophylaxis with intermittent pneumatic compression devices. Hematology reviewed her to see if there was an underlying cause for her recurrent VTE, but they couldn't find one. Prior to her presentation, for about a month, she'd been experiencing some headaches and had attended her general practitioner who had organised an MRI of her brain. At the time, these were reported as mild periventricular chronic small vessel ischemia. When she presented to us, we took a look back at these images, and retrospectively, there was evidence of chronic microhemorrhages in cortical areas consistent with the diagnosis of cerebral amyloid angiopathy. And we then had an important discussion with the patient about balancing bleeding versus clotting risk, and an explanation of what cerebral amyloid angiopathy was. So here I have an image. This isn't our patient, but of an MRI image on the left showing very small areas of microhemorrhages on an MRI scan, which would be consistent with a diagnosis of cerebral amyloid angiopathy. Basically, there is amyloid deposition in the cerebral blood vessels leading to leaky blood vessels, and these patients are prone to bleeding and have a high rates of recurrent bleeding. On the right, we have the Boston criteria, and this is a criteria to help us diagnose cerebral amyloid angiopathy. Definitively, it must be diagnosed on histopathology, but the Boston criteria help us diagnose it with radiology. So patients must be over 50 years of age, have a typical clinical presentation, so that's either bleeding, stroke-like symptoms, or transient focal neurological episodes, or also cognitive impairment or dementia. Their MRI must have typical findings, that's usually bleeding at the lobar distribution or evidence of prior bleeds, and they must have an absence of any other obvious causes of bleeding. Unfortunately, the case was very complicated, and she developed acute chest pain and syncope 3 weeks into her presentation. A PE was diagnosed in a CTPA. Then we had the situation of what we were going to do about her anticoagulation, given her recent bleeds. The case was discussed with hematology. She was commenced on tinzaparin, and she had a minimum of 6 weeks therapy to treat her PE. For long-term prevention of PE, an IVC filter was placed, and this was due to the high bleeding risk associated with being on long-term anticoagulation with a background of CAA. She had a fantastic outcome, so full neurological recovery. She was completely independent on discharge. We see her regularly in the outpatients, and she's doing extremely well. We also have discussed with her the risk of recurrence with intracranial hemorrhage and cerebral amyloid angiopathy. That this has happened. She's had a great recovery, but unfortunately there is still a risk going forward. As regards to anticoagulation, this was stopped at 6 weeks after her event, and her IVC remains in situ. So this is a complex case where there's no clear evidence about best management of these patients, and it's about balancing risk, bleeding versus clotting risk, and it's important to clearly communicate this with patients, and also about the lifelong risk of bleeding with cerebral amyloid angiopathy. We also found that there's increased clinical significance of cerebral amyloid angiopathy. So with increased MRI, you can see these events which may be asymptomatic, so not have those typical presentations. And what do you do about those patients? How do you manage them going forward? And the Boston 2.0 criteria is very helpful with this, coming up with this diagnosis. And for this patient, a multidisciplinary approach was extremely helpful and led us to the diagnosis. So in conclusion, a very complicated case. So treatment of two conditions, which required kind of opposite treatment, and it resulted in a clinical dilemma. But fortunately for this patient, we had a fantastic outcome, and she made an incredible recovery. Thank you.
Thank you very much. Now, time for questions.
Well, it sounds like a typical patient of Dr. Ducatis, who is getting the microphone, hope soon.
Yeah, thank you. Very nice presentation. There's a lot to unpack there. Just a couple of quick comments before I get to my question. Number one, this is the type of patient that we hope the emerging factor XI inhibitors will be suited for, where you really can't anticoagulate, but there's a high thrombotic risk. So time will tell whether these see the light of clinical practice. My second comment is the use of the andexanet alpha, and it's controversial. I'm not sure I would have used it in this circumstance. Why? Because I'm not sure it would have affected the clinical course, but more importantly, because it's a factor 10 decoy molecule, it can have prothrombotic effects. So one has to use it with caution in patients with prior history of thrombosis. And my last question is, so you treated this patient for 6 weeks, or was it what was the kind of thinking process? Why don't you walk us through that? Because a lot of this is back and forth with the patient.
Exactly, yeah. So there was no kind of clear guidelines on how to manage these patients, and we discussed it with multiple hematology teams across the country, and there was no kind of clear consensus on what to do, but eventually it was felt that the area with the least risk associated with it would be the 6 weeks of treatment, and then in the interim having an IVC filter placed. But like I said, there's no clear guidelines on that, and there is, that was the overall that felt to be the best treatment for our patient.
I think that was, again, fantastic. It's going to be hard for the judges to decide, but a fantastic case. Just a pearl that I wanted to share. There's also some data. It's not the greatest data, but when patients see their primary care physicians, a lot of them are getting risk stratified for lipid therapy. And there's some data that statins can also increase the risk of microbleeds in patients with CAA. So it's just something just to be aware of, that all strokes are not atherosclerotic, and everyone with abnormal LDL levels should not be treated with statins, especially perhaps in the setting of CAA, because of the increased risk of microbleeds in this situation. Just wanted to share that with you.
A couple of comments. The first one, it's a real case of risk and benefit a lot of question about that. The second thing is the amyloid angiopathy in a so young patient. Do you have any idea of the cause of that, and is it related to the hypercoagulable state?
We didn't have any clear reason as to why she had developed this. There was no kind of obvious reason. To be honest, I suppose it's seen typically in patients who are over 50 or 55 as per the guidelines, but there was no obvious reason as to why this happened for her.
And I'm also joining the thing that the primary care physician missed the first signs of the bleeding. And I'm not sure that statins are a very common cause of hemorrhagic brain bleeding. It's a very, very, very rare case.
Thank you. Last question,
Okay.
if there is any. Akbar, please.
Just wanted to ask you, we use anticoagulants so freely these days. So what is the risk of bleeding in the brain as a result of anticoagulation in patients with the cerebral angiopathy? Should we be doing CT scans on people before starting anticoagulants?
Exactly, it's very complicated, and I suppose when I was working on stroke, I see quite a lot of this cerebral amyloid angiopathy diagnosed based on MRI, and it makes you concerned, I suppose, if you're in a fast call and if the patient presents in time for thrombolysis. Just thinking in the background how many recent cerebral amyloid angiopathies I've seen, you know, just I suppose we have to be aware that it's there, and perhaps you know, thrombolizing these patients, I suppose it makes it a little bit more difficult. You want to almost have reviewed their previous imaging before you think about progressing to thrombolysis. I suppose it's a really hard one, but I think we should be aware of it going forward. I'm not sure if I think it would have to be an MRI scan that would have to be done to kind of pick this up rather than a CT. And I'm not sure about the feasibility of doing that for all patients who are required to start anticoagulation, but it's certainly something to think about for sure.
Okay, thank you very much.